Hello, everyone. I just wanted to take a second and go over the study guide for Test 1. Now, a few disclaimers up front. Like always, this study guide, and in fact, all study guides, shouldn't be considered comprehensive or entirely reflective of what's on the test. But this is just my way of saying, hey, here are the most important things. Here's what I would highlight if you had limited time. And, even the review here shouldn't be considered entirely reflective. But I guess I would just say that if I mention it here or it's on the study guide, it's certainly worth knowing and I think a valuable use of your time. I still have the outdated study guide here. You might not necessarily recognize this version. I've updated it, formatting in certain context and whatnot. And additionally, I've got some music playing in the background. It may make you think that you're about to go out to do some yoga or experience a massage. Neither of those things are about to happen. Many regrets. It's mostly just to remind myself to keep appropriate tempo. So, a few general concepts. Patient assessment, super duper important. And the order of operations, all the more so, knowing when to do something and knowing when to do it next. And then additionally, just knowing when to repeat those things because many of them should be repeated as it appears necessary. Scene size up is largely determining whether or not you're safe to proceed and if you have everything that you need to proceed. And then shortly after that, we go largely into what the patient needs and what we can do for them. Just remember that your general impression is you taking in the scene, that you take the scene in and every time the scene changes. So as you go from room to room or from home to home or whatever the case is, what do you see? What do you smell? All these kind of things. We see in class a lot if you see a nail, hit it with a hammer. And I'm often thinking that we should add later walk around the nail or hit it again or some version because we really need to reassess everything that we have done, including our interventions. And so, I often take to saying that there are three major points in patient assessment regarding life threats. One is our obvious life threats, is expressed by saying obvious life threats. Then there are life threats that are maybe less obvious but still apparent, and those appear in the ABCs. When we discover them, we're going to address them immediately. And then thirdly are maybe the hidden life threats that were not obvious and not super apparent. And maybe these are revealed during our physical assessment or just assessment that is performed later. So again, make sure that you're identifying immediate interventions and that you're immediately intervening on them. Primary and secondary assessment, we have to be careful that because even though these are chronological terms in a sense, first and then second kind of thing, some of that stuff overlaps. It's okay to give aspirin in a primary if you've identified the need for it. You still need to ask if they're allergic, and that's technically a sample question that would fall in the secondary. So it's important to know that even though we do list these things in order, sometimes they overlap. Pertinent negatives is not only good for writing your PCRs, it's also good for trying to help you solve the mystery of what's happening. I think this person is having a heart attack, so therefore I think they should be experiencing chest pain. The fact that they're not experiencing chest pain is interesting and might be a pertinent negative that's pointing us away from our original diagnosis. Level of consciousness, you got to make sure that you understand AVPU and how to determine level of consciousness, being able to make the distinction between each of these categories, and then also how the Glasgow Coma Scale relates to that. Of course, the first category is AVPU in a nutshell, and you need to know that GCS can be tricky and therefore, doesn't occur often in the primary, usually in the secondary, and often while we're transporting before calling in a radio report, largely just to communicate to the hospital the neurological capability of our patient based on the number that's achieved. Don't forget that all people get 3 points for showing up and that you can have a max of 15 points. You don't ever want to say somebody's GCS is 0, a 1, or a 2. And also just note that even a person who is only confused loses 1 point and isn't at 14. So just some general concepts about the Glasgow Coma Scale. Make sure that you can differentiate the difference between level of consciousness and mental status. Of course, one being lethargy and more indicative of a failing patient status or a losing fight, whereas confusion might be a earlier sign. These can be difficult to distinguish and might be a line sliced a bit thin, but it's worth noting the differences between those because it's going to affect our treatment and our predictability of patient care, or the patient outcome, rather. Now, we didn't explicitly cover MedLegal during this course, but part of patient assessment is simply knowing who you can and can't assess. You know, what gives a patient a right to refuse is still just as relevant here as it was before. So if you're not familiar with those concepts about consent, make sure that you review that so that you're prepared to answer the questions that might be a little tricky about a patient who is in need, but just maybe isn't interested in your care. Continuing on through talking about chief complaint, just know that this is specifically it's what a patient says is wrong. You know, if a guy says my chest is hurting, and you arrive to find that he's got a branch in his chest because he fell out of a tree and landed on one, I mean, his chief complaint is still technically, I suppose, chest pain. You know, might change the way you call in a radio report. Might be misleading if you say chest pain without any clarifications, but I mostly may just mean to say here that it can be important in less obvious situations. You know, guys got chest pain and difficulty breathing, and you just ask them, hey, what's wrong today? If I had a magic wand and I could only fix one thing, what would it be? And that's his chief complaint, and that's what we're largely going to go after because, you know, his body is telling him what is wrong. Make sure that you understand all the letters and their association for sample and OPQRST. There are fancy words like palliation and provocation that just largely mean what makes it better and what makes it worse. They're all important concepts to understand for patient assessment. You also want to be able to highlight the differences between the types of pain presentations, somatic being sharp, visceral being vague, focal being local, and diffuse being wider spread, or perhaps even my entire body. Make sure that you can differentiate radiating and referred pain. Of course, the trail is the large indicator there for radiating, meaning that pain is felt perhaps in the shoulder and in the bicep and in the forearm and in the hand. And so we can trail along the pain there, whereas referred pain is largely just pain in a place that is separate from the origination of the issue. Know that guarding can be involuntary or voluntary. If you swing at my face, I'll guard myself by raising my arms, but largely guarding is referred to an abdominal experience where even an unconscious person, you might palpate their abdomen looking for injury and find that their muscles tense up in defense. And so in either case, we would describe that as guarding. Now we have an entire chapter, in fact, several courses, I want to say. I mean, just huge portions of our courses, if nothing else, dedicated to airway and respirations and the like. And so we're really going to go in depth on this later on, but an enormous part of your patient assessment is, are there life threats and are there continuing issues that I can immediately affect that would help somebody? And airway is a large portion of that. Not only do many of our patients have airway problems, but we can directly affect them with interventions as well. So just make sure that you understand the different steps of airway management, knowing that we need to open the mouth to get air in and out. We need to adjust the head as appropriate so it can get into the throat. And then there are various medications and interventions that will affect the lungs. And so each step of the way needs to be kind of evaluated and assessed appropriately. Make sure that you understand that aspiration is largely people that have had the contents of their GI tract come up into their oral pharynx and then down into their airway, that this can be a major problem, especially for our patients who are nauseated or vomiting, laying supine, or just prone to these issues in general. And aspiration is a major problem because obviously air is just about the only thing that belongs in your lungs, because anything that isn't air is prone to collecting infection or even obstructing the airway. Make sure that you know what OPAs and NPAs are and who they're for and who they're not for as listed on your intervention cards. It would definitely be worth your time to review that, because even though we cover these things in BLS and superficially through our labs and the like, make sure that you understand the indications and contraindications for both of these, because they can be a little tricky. You know, differentiating someone who doesn't have a gag reflex from someone who is unconscious, or I guess I mean to say, make sure you know the difference between unconscious and unresponsive. Make sure that you also know who can receive various manual maneuvers, right? We've got head tilt chin lift, we've got a jaw thrust. Later we'll talk about a tongue chin pull, tongue jaw pull rather. We'll talk about sniffing position and all kinds of different things, modified jaw thrust and the like. So make sure you're reviewing those things and you know who can and can't receive which. It is important to understand the fundamentals of breathing, being able to differentiate upper and lower airway sounds and what their causes are and what their corrections are. I've included a link to this video here. It goes a little in depth for what we need right now, but it is an incredible use of your time. I think that it will translate to some success on this test, and it will absolutely lay the groundwork for what we'll be discussing over and over and over as the course continues. Just don't get too tricked by terminology like bronchovesicular and vesicular or adventitious. I mean, some of these terms almost have an inverse property where bronchovesicular sounds abnormal and adventitious almost sounds like advantageous. So just make sure that you know that those common misconceptions are misconceptions in general. Make sure that you also understand your rescue breathing rates, because even though we haven't specifically gone into airway yet, it's part of our ABCs to identify the issue that's causing the patient distress and be able to correct those things. And then also make sure that you're able to understand that if a patient isn't moving adequate volumes of air, then it doesn't matter if you're administering accurate concentrations of oxygen, or more to the point, or perhaps simply, there are patients who need a BVM, where if you put a non-rebreather on them, they may die. There are patients who need a non-rebreather, where if you force a BVM on them, it may make them worse. And so make sure you understand those differentiations. Make sure that you know what continuous ventilations are, what the rate is, and who they're for, and things like intubation and eye gels, or just maybe a person with a pulse who merely just needs your help with ventilations. There's tricky numbers in there. I recommend that you kind of work out in your mind what it would mean to give it every so-and-so seconds, what that would look like if you gave it every so-and-so seconds, how many that is per minute, because there's some confusing and some misleading numbers in there. Also, you want to make sure to know why mouth to mask is the safest. And to put very simply, I think you could read a decent amount in the book and still kind of miss this point. So I'll be happy to highlight it here. Mouth to mouth is mouth, not mouth to mouse. I don't recommend that. Mouth to mouth is not the safest because you are swapping fluids with a patient. So it's not very safe for you. Mouth to mask is safer than a BVM because you could overinflate a BVM, but you can't really overinflate mouth to mask because you're going from your lungs to their lungs. Now, I'm not recommending that necessarily, but what I do like talking about in this aspect is how barometric trauma, pressure issues, and overinflation of lungs is a very real issue, and a BVM can do all of that, where you breathing into a patient's lungs is far less likely. So I just mean to highlight the fact that a BVM is not innocuous, that it can cause major issues. So I just want to talk for a second as well about circulation and shock. This is another enormous part of patient assessment that we'll go into far more depth later. You have to know what shock is. You have to know that it's indicative or synonymous with hypoperfusion. And you kind of have to know the progression, at least superficially. You have to know that shock in general is a lack of oxygen and nutrients in my organs and tissues where I need them. Now, even though I said oxygen, it doesn't necessarily imply a breathing issue. Of course, the oxygen and nutrients are carried by your blood, so even if you're breathing okay, you might have a separate perfusion issue that has more to do with your heart rate or your blood vessels or the amount of blood. And so shock isn't necessarily poor breathing. It largely means that stuff's not getting where it needs to get, or maybe even that it's not getting out in the way that it needs to. So early signs of this are going to be anxiety, altered mental status, tachycardia, and tachypnea, though admittedly, I don't necessarily mean 101 for adults. I largely just mean increasing heart rates. It's easiest to teach that a heart rate of 101 and above should be considered compensation, and that is where we start. But again, a heart rate that's 90 that was, 60 merely 2 minutes ago, that is a major increase and should be considered to be a fast heart rate, even if not technically tachycardic. So just be considerate of these things. As heart rates increase, as respiratory rates increase, as our work of breathing increases, as our level of anxiety increases, these are all signs that our body is stressing and working. The antithesis of that, or rather the inverse side of that, is of course if our body is failing the fight now. If our pulse is starting to decrease, you might say, well, that's great, they're getting better. Well, I hope so, but not necessarily. It might not mean that their heart doesn't need to be beating fast anymore. It might mean that their heart can't beat fast anymore. The fact that they have pallorous or cool, clammy skin can be a sign that their body is saying, I'm not getting the oxygen and nutrients or the blood where I need it, so I'm going to shunt it away from the skin to save my brain, to save my lungs. Clammy, if you weren't aware, means damp. And to put simply, I would tell medics in the field very often, I'd say, hey, I'm getting Discord messages. I would say, hey, if your patient is wet on the skin, it's because they're moving fluid around in their body. Their body is concerned with the amount of fluid that they do or don't have, right? So put simply, when you're under stress, when your body is in shock, you will release adrenaline. And that adrenaline will raise your heart rate and constrict your blood vessels, which will raise your blood pressure, and that's all good, but it also makes you sweat. So in summary, a sign that a person is sweating is a sign, or rather the sign that they're sweating is indicative of shock. Make sure that you know that thirst, right? You ask a person, how are you feeling? And they say, well, I'm just so thirsty, I can't get enough fluid. Well, it either means that they're low on water, or oftentimes that they're high on sugar or have a lot of sugar. In any case, vital signs increasing are signs that the body's fighting the fight. Vital signs that are decreasing and decreased work of breathing, decreased work of the heart are all signs that they're losing a fight, perhaps. Make sure you know that hypotension is one of the last things that we'll see before they die. We shouldn't wait for that for treatment. Perfusion is synonymous with, or I should say hypoperfusion is synonymous with shock, right? So if I'm not in shock, we can assume that I am perfusing well, that my oxygen, nutrition, or nutrients are getting where they need to. I want you to be able to differentiate hypoxia, hypoglycemia. Essentially, hypoxia is hypo, low, oxia, or xia maybe, oxygen. And then likewise, hypo being low and glycemia being sugar. And that sugar and oxygen are the two fundamental parts of the equation to make energy and to make life. And so sometimes they look very similar. A person that might be pale in skin or clammy in skin, it may be a sign of shock due to hypoperfusion, but it also might just be hypoglycemia. And so I guess I mean all of this to say that if you see a guy who looks sick, but you don't think it's bleeding, you don't think he's low in fluid, and it's certainly not a breathing problem, well, then you should highlight checking the sugar, because that's the other part of the equation. Capillary refill is quick and easy, and it's why we use it in a multi-casualty incident for assessing people's perfusion. But in many cases, it's just effective for checking pediatric perfusion, because adults will vasoconstrict so well that it will not be largely reliable in many ways, whereas it can be much more helpful in pediatrics. Make sure you're reviewing our BLS thought processes about AED use, when to start compressions, look, listen, and feel, and all of that. Of course, during patient assessment, if our patient goes into cardiac arrest, we need to have fresh in our mind what to do. In transport decisions, essentially, we just need to make sure that we prioritize getting off scene and getting to where we need to go, but not so much so that we neglect good patient care, not so much so that our scene anxiety increases and prevents us from doing treatment before we leave. Make sure that you understand some of the fundamentals of significant mechanism of injury. I don't expect you to memorize the chart, but I do expect you to know some of the more outstanding and prominent issues there. And I'm not trying to trick you, but I do think that early in our career, it can be very difficult to determine The nature of the illness, or specifically the mechanism in this case, or maybe more to the point, is when a patient doesn't look sick, the earlier we are in our career, the easier it is to be deceived by that. And so make sure that you know that there are some things that kind of transcend the patient's appearance. You should be able to differentiate golden hour and platinum 10. Now, I don't think these concepts are largely pushed or even largely taught anymore, but I do think that it's important to emphasize to students that in many cases they should aim to be off scene in 10 minutes, specifically for trauma, and that first 60 minutes, or the sooner we can get them to definitive care, oftentimes the better that they'll end up. It's not to say that we should sacrifice the definitive care or the specific care that we perform on scene. Wouldn't it be a shame if you, in your hurry to get this trauma patient to a surgeon, you missed a life threat that only required pressing a gloved hand on it and therefore they perished? Understand that by vaso, we're talking about your veins and arteries, and that by constriction, we mean narrowing those vessels and therefore increasing your blood pressure. And that by dilation of those blood vessels, it means lowering your blood pressure. And we can prove that simply by squeezing a water bottle. As you squeeze a water bottle, you narrow it, you constrict it, and you'll see the water rise. And by nature, the pressure inside will go up. Understand these different skin presentations, that pallor is pale, largely means a lack of fluid to the area, and cyanosis is perhaps more indicative of fluid that's getting to the area, and specifically I'm referring to blood in your tissues here, but may not have the oxygen content you need. Now, in either case, these patients need oxygen or supplemental oxygen, but differentiating them can be helpful. Mottled skin, which I recommend you Google. It's an interesting spidering of capillary expression, just redness kind of cast across a pale hand or arm or legs, can be a sign of poor perfusion and often a sign of heart failure. Jaundice is a yellowing of the sclera in the eyes or the skin, indicative of liver or perhaps kidney failure. Diaphoresis isn't just sweating, it's pathological sweating. If I run up and down the stairs and sweat, that's not diaphoresis. I'm just sweating. If I'm just sitting in my car and start pouring sweat, that might be a sign that my adrenal glands are kicking up and causing some kind of issue. Urticaria is a way to say wheals or rash. It is strongly indicative of an allergic reaction. Make sure you can differentiate the pupillary signs. Knowing the words is important, knowing how they look visually, and then also knowing the causes. Things like meiosis or a constricted pupil is indicative of pupils constricted lower than a 2, and light can do that. You shine light in somebody's eyes, that will be a cause constriction. But so too will opiate use. If you took a bunch of heroin, for example, that can cause constriction of the pupils. It may not always do it, but if it does it, that's a pretty clear sign. Just don't be too deceived. If I take Percocet, which is an opiate, every day for 20 years for my back pain, it may be prescribed and done completely legally, but it might chronically constrict my pupils. So it can be misleading sometimes, the idea of the pupils, but it's something worth noting. When we talk about Perla, even though accommodation, the A, is not often assessed in the field, it's largely tested by moving an object closer to somebody's face, like if I bring my finger close to your face, and so that too should cause constriction. So there's a lot of things that can cause all of these presentations, and I've just kind of done my best here to highlight what might be correctable or worth considering immediately. When assessing the abdomen, make sure that you are familiar with these other pain presentation signs, or these other signs that are indicative of issues, things like distension, meaning a swelling. Often ascites will do this. Fluid in the abdomen or the perineal space, perineal space, I should say. Guarding, we talked about. Rebound tenderness, which of course means pain as you release pressure, not when you push pressure. Often indicative in that lower right quadrant of appendicitis. Make sure that you can differentiate all the letters of DCAT BTLS. This is what we're going to be looking for when we're looking at a patient's body, looking at their head for any signs of deformity, contusions, and so on through all of DCAT BTLS. And also make sure that you understand these vocab words that are not used in common language, like crepitus, which is the sound of bones grinding, and then priapism, which is a erectile issue, essentially, what can often happen is, I guess I shouldn't say often. In fact, I would say rarely. But what can happen in spinal trauma is that you dilate all of your vasculature because you no longer have tonality of the sympathetic nervous system. So you get hit in the spine, all of your blood vessels dilate, and they fill with blood. Well, when a penis fills with blood, it will become erect, and we call that a priapism when it's a pathological erection, not a physiological, not a normal one. So you can get this either from spinal trauma, or you can even get it if you have some type of trauma to the penis, or if you have taken erectile dysfunction drugs, maybe to excess. So make sure you're familiar with those words. They're not highlighted largely in class, and it's worth noting. You just got to be sure that you know how to talk to people, honestly. Know that you can't force anybody to say anything because you're not a cop, and know that it's inappropriate to dig deeply into people's sexual experience. It might be valuable to know if they're sexually active, because then that might mean that they're pregnant, or it might be an explanation of why their genitals hurt or are having injuries or wounds. But they don't have to tell you anything. And so make sure that you are kind and you're understanding, and that if they don't want to talk to you, then they don't have to. Make sure you understand all of your vital signs ranges for adults, specifically systolic blood pressure ranges and references to MAP. Make sure you understand that pulse oximetry specifically measures oxygen molecules bound to hemoglobin, meaning that it will measure carbon monoxide, which is deadly, and say that it's 100%, and it'll also measure carbon dioxide, but inevitably, or ultimately, it's just measuring how much oxygen is bound to your hemoglobin. It can be very misleading. End-tidal, however, is a measurement of your expressed carbon dioxide. It tells us that you must have taken in oxygen, that you must have been able to get that oxygen into your blood. It very likely went to the tissues it needed to. A chemical exchange happened, which resulted in energy and now carbon dioxide. And we assume all of that because carbon dioxide is coming out of your mouth now. Now, it doesn't guarantee it, but it's a far more reliable narrator for the situation that's going on inside of your body. Make sure that you know that stable patients, what defines their stability and instability, and how often we reassess those vital signs. It's not wise to do it every chance you can. You certainly need to do it at least twice for all patients, but the timing of that might change based on your patient's presentation. So to close here, I just want to reference a few things. You can look into end-tidal and capnography. I do think that understanding these concepts can be helpful, but I don't explicitly require you to know them. We don't go into colorimetric devices really until AEMT. Not that it's not in your scope or not important. It's just to save time, and I don't think that you'll commonly use it, especially in the presence of end-tidal. Pitting edema just means, edema in general means fluid in the wrong place, and pitting means that when you press on it, you can still see your fingerprints. And so it's referenced a few times here in the chapter 10, but I don't get into it a whole lot until we talk about cardiac issues later. As much as I think radio reports are important, I don't expect you to know it now, and it's not super helpful for the test. I've included a couple of links, not only the patient assessment, which breaks down all the most important parts of patient assessment to me, but also the order of operations I expect, and some of those do deviate from the book, so I would say make sure you know that. Here listed is the vital signs, the detailed vital signs, and if you haven't checked this out yet, I think this is great because it really gets down to the nitty-gritty about what each of these signs are and what you can expect from them. So I really recommend that you read through this at least once. It may look complex and it may be relatively in-depth, but it's broken out simply, and I think that it can be very, very helpful. This is just my approximate breakdown, essentially. I just counted up all my questions and tried the best I could to kind of group them and to give you a rough idea if you said, okay, well, I'm studying this, how much of this is on the test, I mean, don't be too overwhelmed or spend too much time diving into differentiating compensated and decompensated shock, even though we use those terms. It's only going to be 5 or 6 questions on the test. It's an important concept. We go into greater depth later. Anyways, I wish you guys good luck. Feel free to email me if you have any questions. And if this video has been beneficial at all, please let me know that, because it takes a decent amount of time and preparation. But I'm happy to kind of help you guys in any way I can. I hope you have a great day. And like I said, good luck.